The biggest unmet medical need right now in HER2-positive advanced breast cancer, I think there are twofold. One is that while there are a number of different options that we discussed in the previous part of the talk for treating patients in third and later line, combinations of chemotherapy and HER2-directed therapy, none of them have been shown to have high rates of efficacy. In general, studies suggest response rates in the 20% range and with progression-free survival in the 5-month range for patients who've heavily pretreated HER2-positive disease. So clearly, more efficacious regimens would be helpful for such patients. The other unmet medical need is brain metastases, which unfortunately is a common occurrence in HER2-positive metastatic disease. Some studies have shown up to 50% of patients with HER2-positive advanced disease will eventually develop brain metastases. These brain metastases typically respond well to radiation, but in some patients, continued recurrence happens after radiation, and eventually radiation options become limited, and at that point we really don't have good treatment for such patients. To identify and develop new treatments for patients with treatment-refractory HER2-positive breast cancer, a number of different options have been looked at. One is antibody-drug conjugates. We already have an approved antibody-drug conjugate for this disease, which is TDM1. So what is an antibody-drug conjugate? So basically, it's a monoclonal antibody, in this case, typically a HER2-specific monoclonal antibody. But rather than give a free drug, such as we do with trastuzumab or pertuzumab, we link it via a chemical linker to some cytotoxic agent. So with TDM1, it consists of basically trastuzumab linked to a cytotoxic agent that's a microtubule inhibitor. That's the DM1 component. And the idea is that we take advantage of the specificity of these antibodies. So when you inject TDM1 into the bloodstream, the trastuzumab component of it brings the molecule directly to the HER2-positive cancer cell, but now it's bringing along with it the microtubule inhibitor cytotoxic payload. So the idea here is that you're able to selectively deliver this cytotoxic agent directly to the cancer cell. Because it's linked to the antibody, you minimize the amount of toxicity that happens when the payload interacts with normal tissues, as would happen if you were using a free chemotherapy. So it's essentially a way of giving trastuzumab plus chemotherapy, but in one package to minimize the toxicity and improve the therapeutic index of your cytotoxic agent. So TDM1 provided the first proof of concept in a solid cancer that this antibody-drug conjugate approach can be effective. And basically it does exactly what it was designed to do, which is effectively kill HER2-positive cancers and have a relatively manageable safety profile.